Okay. The speaker today is Brendan Kelly, who is coming to us from the University of Pennsylvania and the Hospital of the University of Pennsylvania, where Brendan is an assistant professor. Brendan is doing fascinating translational research that he is going to discuss today with us. Brendan is a faculty candidate who we are very excited that he's come to visit. So with that, Brendan, I'm going to turn it over to you. If everyone can remember to mute their Zoom so that we can all hear Brendan clearly. Thank you.
Okay, thanks so much. It's really been a pleasure to visit this morning and meet with different members of the division. And it's as someone who grew up in South Jersey, it's also always an honor to be invited to Rutgers, and happy to spend the day with you all. I'm going to talk today a little bit about work that my group has been doing to try to understand better the bacterial ecology of infection and understand a little bit better why and when antibiotics fail. And I'm going to try to sort of broaden the concept of antibiotic failure a little bit and hopefully convince you to my way of thinking. No conflicts of interest, and all the work I'm going to talk about is supported by NIH and CDC. So again, I want to focus on this concept of antibiotic failure. And I think this is something that we as infectious disease physicians think about every single day. In fact, this is sort of a huge part of our job. And I think, typically we think about failures of pathogen identification, that is when we're choosing the wrong antibiotic or someone else has chosen the wrong antibiotic. And we worry about high-grade phenotypic resistance when we don't have sort of full culture susceptibility data back. I spend much of my time on the general ID consultation service worried about inadequate source control. I suspect many on this call do as well. But I want to emphasize sort of a third piece of antibiotic failure, which is, I think, something that I didn't think a lot about, but that I think more and more about every day, which is what happens after antibiotics are done, that is after a sort of definitive, appropriate course of antibiotics are done, and what happens with microbial repopulation of the respiratory and gastrointestinal tracts. And I'm going to try to convince you that this post-antibiotic repopulation is also something we as ID physicians should be thinking about, and that there are sort of tools on the near horizon that are coming that will help us, hopefully as leaders, exert new influence over post-antibiotic repopulation. And I'm specifically going to go through work to try to make this case that looks into the bacterial ecology of infection. My own focus has been on VAP and C. diff infections. I'm going to talk about some studies we've done looking at microbiome change during and after antibiotics. And then I'm going to wrap up with some of the interventions we've been developing to try to engineer post-antibiotic repopulation. But before I dive into the bacteria, I'm going to spend just 2 minutes talking about islands, not just because it's 15 degrees out today and it's nice to think about warm water and bright sunshine, but because islands actually are sort of an important concept in the way I think about this repopulation problem. And I'm going to tell you about work that was done over 50 years ago now in the 60s. So this is a book called The Theory of Island Biogeography by Ed Wilson, who just passed away recently, and Robert MacArthur, that made a big splash in the 60s and has continued to be very influential in thinking about island ecology, where they try to formalize mathematically sort of what determines how many species are on an island, among other things. And thinking about islands as a balance between immigration of new species and extinction of the species already on the island. And this, again, was published to acclaim in the mid-60s, but Ed Wilson was not really a mathematician and wanted to really decide if this mathematical theory had any real world validity. He wanted to do an experiment. And so he did sort of a crazy experiment. He went down to the Florida Keys one summer in the late 60s. And if you can see on the right here, these tiny little specks with arrows next to them, he found these sort of tiny mangrove islands off the Keys. And he measured the diameter of these islands, how far they were from the nearest shore, and how many arthropods or insects he could find on the islands. And here's a picture of these tiny little islands. Here's his grad student, and here's Ed Wilson standing in front of these tiny little islands in the Florida Keys. But the crazy thing he did was he went to Miami and found an exterminator and had them cover these islands with tarps and pump insecticide into them. And he had a good reason for doing this. He wanted to measure, after you eradicated every last insect off an island, how long it would take for the insects to come back, and compare how the distance offshore and the size of the islands made a difference in terms of how quickly the insect populations recovered. But I have to admit, when I first saw this photo, Ed Wilson was later in his life sort of famous as an ecologist. The idea of sort of covering up these islands and pumping them full of insecticides struck me a little bit as a little bit off. And then I thought of myself in the ICU, and I think we in infectious disease pride ourselves on being good stewards of antibiotics and being targeted in our antibiotic therapies. But there are those patients in the ICU where even we agree, Dapto, Miro, Caspo, maybe a little amikacin on top. And I sort of, as I stared at this photo of the island covered in a tarp, I had an image of myself writing a consult note in the ICU and pumping someone full of all these antibiotics. And I think it's an image I want to leave you with, because I think just like Ed Wilson wanted to figure out what happens after the extermination, I think we as ID physicians are going to be thinking more and more, particularly as novel therapies become available, about what happens after the antibiotics. And so why does post-antibiotic repopulation matter? Well, in one way, I think it matters because failed repopulation risks recurrent infection. So we know that from studies of even healthy human subjects who just get sort of an oral cephalosporin, that it takes about 3 months to sort of fully recover the diversity of the gut microbiota after antibiotics, and the recovery never looks exactly like the pre-antibiotic state. We also, I think, all know a very sort of the key example of where post-antibiotic repopulation fails, which is recurrent C. diff infection. C. diff infection of colitis, of bacterial colitis, has about a 20% rate of post-treatment recurrence, and interventions like FMT or fecal transplant, which are targeted to redesigning repopulation after antibiotics, have a very good success rate in resolving recurrent C. diff colitis. But also, there is data to suggest that bloodstream, respiratory, and urinary tract infections also.
Well, that's Dr. Chen.
Hi, Dr. Chen. This is Elaine Bermuda calling from Sweat Equity Group. I got your number from Dynata. You had
And Leah, please
about your
mute.
use of a lipid product in your.
So I think bloodstream, urine, and respiratory tract infections also there's some data for. And this is something we looked at ourselves. So this is work done by one of my mentees, Matt Ziegler at Penn, who's interested in the hem-onc population. We looked at over 10,000 hem-onc patients admitted to HUP over 11 years from 2010 through 2021, and found about 7,800 of them who had either a blood, respiratory, or urine culture obtained. About 1,000 of them had bloodstream infection determined by a positive blood culture and clinical signs of infection, 215 with a positive respiratory culture, 845 with a positive urine culture. And then we looked at over 180 days thereafter what the recurrence rates
stuff,
were.
and I wanted to take it out as soon as it ended, and I forgot.
Mel, please mute yourself.
Sorry.
What the recurrence rates were of the same genus or a different genus of infection, and found pretty sizable within 180 days recurrent rates of infection. 286 recurrent infections, bloodstream infections with the same genus, and 208 with a different genus. And we were interested in particular about the timing of these recurrent post-treatment infections. And so we did some modeling. This is what's called a hurdle model to try to look at the number of days across blood, lower respiratory tract, and urinary tract infections where the peak of risk for recurrent infection exists. And so you've got on your x-axis, on the horizontal axis here, the days to recurrent infection, and then the 3 lines are the different forms of infection. You see that the peak risk for recurrent infection, both with the same genus or with a different genus, is right in this sort of like 60-day range, 45 to 70-day range. It varies a little bit across infection types, but that seems to be sort of the peak period of risk for recurrent infection, which again is in line with this thinking of about a 3-month period from both animal studies and small human cohorts, that it's about a 90-day period of repopulation after antibiotic treatment.
Brendan?
Yeah.
Maybe you're going to answer this. Within the same genus, how much is the same species or the same strain?
Yeah, so this is, you're right, Marty. This is sort of aggregated at the genus level, and we're still breaking this down. And I don't want to dive too much into this, but there are some interesting antibiotic effects, that is, effects of different classes of antibiotics within the same genus that we're also digging into. This gets a little bit to your question here. So here's just looking at recurrent infections with the same genus, bloodstream, lower respiratory tract, and urinary tract. Again, on the horizontal axis, you've got days to recurrent infection, and we're trying to model what the peak risk period is. And here we're looking at differences across different genera within these different categories of infection. And you see there are some blank spots. That's where we didn't observe, for example, any Proteus bloodstream infections, but we did observe a Proteus urinary tract infection. Likewise, we didn't observe Enterococcus lower respiratory tract infections, so those are missing. But you can see here that there is some heterogeneity. In particular, Enterobacter seems to have sort of a little bit of a wider range of recurrent risk, and we're sort of, again, diving into some of the particular antibiotic effects that may be associated with this. But I think this emphasizes, again, that there is this sort of risk period of recurrent infection. So that's one reason why we should care about post-antibiotic repopulation, is that it's not just C. diff, that we have a recurrent infection problem. The other reason I think we should care about repopulation post-antibiotics is that there are huge opportunities for novel therapies in this period. So obviously, FMT, or fecal transplant for C. diff, has been demonstrated to be very effective for recurrent C. diff. And I'm going to tell you a little bit about some pilot work we've done to look at its efficacy for severe C. diff. But there are a lot of other applications in development. And some of the most exciting data has come from our colleagues in oncology, where recently, just within the last year, there have been a couple of papers published to suggest that FMT can be a really powerful intervention to overcome resistance to or potentiate therapies for cancer. The sort of peak example of this is FMT taking people who are non-responders to anti-PD-1 therapy or immune checkpoint inhibition and making them responders. And this is getting a lot of attention and a lot of follow-up investigation right now. There's also a little bit of data, mostly in animal models at this point, that FMT can actually be a powerful tool to potentiate response to chimeric antigen receptor, or CAR T therapy for cancer as well. So this immune gut microbial interaction, I think, is another reason we should really care about antibiotic repopulation. There's also, much earlier in development, a lot of work going on with synthetic bacteria that may be useful to address metabolic disease, but those are only useful if we can get them to engraft in the gut, right? Only useful if we can control repopulation. So this is why I care about this topic. I think both in terms of preventing harm and enabling new therapies, this is a really essential period to understand. And so I'm going to tell you a little bit about the work that I've been doing to try to better understand bacterial repopulation after antibiotics. The first part of that, as I said, is just looking at features of bacterial ecology associated with acute bacterial infections. And the examples that I focused on, again, are ventilator-associated pneumonia and C. diff. Then I'm going to dive into a little bit of a discussion of what it actually looks like during and after antibiotics, how the microbiome changes, and how different antibiotic classes affect microbiome change. I'm going to mention here too work we've been doing to look at the microbiome of the healthcare environment, because passive repopulation, that is repopulation after antibiotics that's not controlled with an FMT or some other therapy, is an invitation for environmental bacteria to enter the gut. And we've got to better understand what the environmental bacteria look like in the healthcare environment, because that's often where this repopulation is happening. And then finally, I'm going to close with talking about how we can engineer post-antibiotic repopulation. And the two sort of models of this I'm going to focus on are, one, sort of a transplant model where you get antibiotic conditioning and then a fecal transplant or some other living biotherapeutic product, LBP, which is sort of the new term that's being embraced. And the other intervention I'm going to talk about is really early work that we're just sort of getting on top of now, but that I'm really excited about, which has to do with sort of an idea of post-induction consolidation therapy with bacteriophage, which is sort of a chemo or oncology therapy model where you get your induction therapy with an antibiotic, and then you sort of consolidate therapy with phage therapy to potentially better control repopulation. So let me kick it off by talking about some of the work we've done with focus on the bacterial ecology of infection. So the key questions here are, what is the shape of the bacterial community during bacterial infection, during VAP, or during C. diff, and what bacterial community features can aid the diagnosis of those infections? So I'll start by just talking about what got me started in the microbiome field, which was a pilot study that we did back in the mid-2010s, looking at the bacterial ecology of ventilator-associated pneumonia. Our aim was to understand how the bacterial community of the lower respiratory tract and upper respiratory tract changes during critical illness and mechanical ventilation. And this initial study was just a small pilot study with 15 adult subjects who were admitted to our medical ICU. We performed upper and lower respiratory sampling every 48 or 72 hours, roughly speaking, and performed amplicon 16S ribosomal RNA gene sequencing. And we compared our findings in this initial pilot cohort to healthy control subjects who'd been sampled via bronchoscopy. And we were interested in the change in community composition over time. And we're also interested in the relationship between community features and VAP, or ventilator-associated pneumonia. Although I will say here, probably for the first of many times, that these respiratory microbiome studies are particularly challenging to do because, as we all know, VAP is in the eye of the beholder. There's no good gold standard for VAP. And although the Centers for Disease the CDC surveillance criteria of VAE, or adverse ventilator-associated events, have been very useful for surveillance. They're not very sensitive and probably aren't a good stand-in on their own for bacterial pneumonia. So here's what we found when we looked at this small cohort. And just to orient you, you have on the horizontal axis here the subjects, a bunch of control subjects who are sampled at a single time point. Those are divided by black vertical lines. And then you've got the ICU subjects, and the ICU subjects, you see the lines are farther apart. That's because certain subjects we were able to sample on multiple days before they were extubated or expired. Other subjects, we just got a single day of sampling before they were extubated or expired. But you see each of the 15 subjects here with however many time points we captured. And then on the vertical axis, you have what bacteria were found in their lower respiratory tract at the family level, just so it can sort of fit on the slide. And just sort of looking grossly at this heat map, you can see that the control subjects all look fairly similar in that they've got sort of the color indicates the proportion of the total that each bacterial family accounts for in that subject. So you can see that the control subjects all look fairly similar in that they've got sort of a bunch of different bacteria, Lactospiraceae, Leptotrichaceae, Moraxella, Prevotella, Streptococcaceae. So upper respiratory bacteria that we typically think of as associated with the upper respiratory tract had sort of fairly low proportional abundance across a bunch of different families in sort of small abundances across the lower, found in the lower respiratory tract, again, sampled via bronchoscopy. That's in contrast to the ICU subject, where we found that in many subjects we had dominance of a single bacterial family, or in most cases, a single strain, a single amplicon sequence variant that was present in many subjects over time. So here's Staphylococcus, and this was Staph aureus. Over every day this patient was sampled. Here, somewhat surprisingly, was Enterococcus dominant in this patient every day they were sampled. You sometimes see there's a little bit more heterogeneity shortly after intubation. This may be post-intubation carry-through, but then dominance. And again, here's another patient we only had for a single day, but with Staph dominant, and somewhere in here there's a Pseudomonas as well, I think right here. But so a clear sort of visual difference between the healthy subjects and the mechanically ventilated subjects. But heterogeneity across the mechanically ventilated subjects. So there are certain mechanically ventilated subjects that do look a bit more like the healthy control subjects, where they have sort of low abundance of different bacterial families, and others that are dominated by a single bacterium. We sort of wanted to reduce this complex heat map into sort of an aggregate measure of each time point. And often in sort of microbiome studies, when we do that, we calculate something called the diversity, which is sort of a balanced measure of how many different bacteria or whatever you're measuring are present in a community, and then how evenly they're distributed, the richness and the evenness. And we looked at the diversity in the upper and lower respiratory tracts of healthy control subjects, of the initial post-intubation sample, that is mechanical ventilation day 0, and then all the samples beyond day 0, and found that there was this sort of temporal trend towards lower diversity over time. We, in this initial pilot study, did not actually find a statistically significant association with between low diversity and pneumonia, but that in part was limited by our low power and by the fact that there was this secular trend, because all of these subjects with dominance did have clinically diagnosed bacterial pneumonia. And so we wanted to follow this up with a validation study And so we performed a similar study with longitudinal sampling of the lower respiratory tract, but we were interested in being able to capture a longer time period to better understand not just the appearance of acute infection, but also what changes during antibiotic treatment and then what the post-antibiotic period looks like. And so for this second validation study, we enrolled subjects in a long-term acute care facility, an LTAC affiliated with Penn, where we were able to get much longer sampling. And we actually enrolled 84 subjects, and across the 84 subjects, captured over 1,000 lower respiratory tract specimens. All of those specimens were sequenced by 16S. I'll tell you later, we did a little bit more workup as well, but initially, the initial study was 16S ribosomal RNA sequencing, and we also did 16S quantitative PCR to quantify sort of the total bacterial bioburden. And our interest, again, was looking at within subject change over time and also VAP, and we wanted to look at sort of different clinical definitions of VAP, again, because there's no clear gold standard for ventilator-associated pneumonia. And here's sort of a very brief distillation of the study. We compared these so-called microbial disruption indices, or MDIs. So one of them was having a lot of bacterial DNA in your lower respiratory tract. So this was 16S ribosomal RNA qPCR, and how well that predicted the risk for a ventilator-associated lower respiratory tract infection, or VAP, per day. So each day, what your risk of VAP was and what the odds ratio was associated with having a high total bacterial burden versus having just one amplicon sequence variant or one sort of strain that we could find that was dominant, and then having low Shannon diversity. And we found from a purely predictive standpoint that actually having low diversity was the best predictor, the clearest predictor of risk for ventilator-associated lower respiratory tract infection. And here the odds ratio is like about 1.36. And here's the 95% credible interval. It's a Bayesian model. But all of these things had some predictive power, and they just, some were less well equipped at discriminating risk for VAP. We compared a bunch of different definitions of VAP. So one was just your ICU physician sends a lower respiratory tract culture. The other is that they send a lower respiratory tract culture and you've got fever and the culture comes back positive. And the third was that they send a lower respiratory tract culture, you have clinical signs, the culture is positive with the bacterium known to be associated with VAP, and your clinicians actually change your antibiotics, so they decide to treat it. And across all of these definitions, we found that again, there was sort of a trend for all these biomarkers to these microbiome biomarkers to predict VAP risk, but that the low diversity was sort of consistently the winner in terms of best predicting risk. I have to talk about, if I'm going to mention, I just talked about islands, and I'm talking about the lung microbiome. I have to just point you to, even though this is work that I didn't do, really nice work that was done by Bob Dixon and others at the University of Michigan, also sort of taking this island biogeography idea and putting it onto the lung microbiome, but in a different way. They did a really interesting study looking at subsections of the lungs and thinking of the upper respiratory tract as sort of the land, the source of all population of microbes in the lower respiratory tract, and then comparing, how far away you get from the upper respiratory tract and how much difference that makes in what bacteria land in different parts of the lung. They actually, in healthy subjects, did not find big differences. The distance did not make a big effect, but also a cool application of this island model to the lung microbiome, and worth reading if you have time. So that's sort of a quick rundown of some of our work looking at the respiratory tract microbiome. I also just want to touch briefly on work we've done in the gut. And so interested in C. diff infection, we wanted to perform a similar study to look at microbiome features in the gut. Here we wanted to look at microbiome features that discriminate between C. diff colonization and C. diff infection. And so one of the challenges, as many of us know, is that nucleic acid amplification testing for C. diff has a high false positive rate. That is, many folks are colonized with C. diff, even though it's not the cause of their diarrhea or maybe causing no symptoms. We think that enzyme immunoassay testing or free toxin testing is a bit more specific. And so we wanted to compare the gut microbiota in subjects who had only NAT positive for C. diff versus those who had NAT positive and EAA positive as a sort of surrogate for C. diff colonization that is just NAT positive versus infection that is free toxin detectable. And so we enrolled 384 consecutive positive C. diff tests from HUP. These were both inpatients and outpatients. You see the breakdown here, 24% of them just had GDH positive, actually, interestingly. This was a three-step testing algorithm. 55% were just NAT positive, and 20%, or 77 subjects, were GDH and EIA positive. And NAT positive, we did validate this. We did stool 16S ribosomal RNA sequencing and the 16S ribosomal RNA gene qPCR. And again, the comparison was infection versus colonization. We also did, although, I will show you a little bit of it, fecal lactoferrin testing as a sensitivity analysis. So because EIA isn't a perfect marker of C. diff, of true positive C. diff disease, we also measured colonic inflammation via this stool marker, fecal lactoferrin, and compared that to gut microbial features. And there's a lot here, but again, just to sort of drill down, one of the first things we looked at was just how well clinical testing correlated with the fecal lactoferrin. And so here you have on the far left just the GDH positive subset. Now, again, all of these subjects, none of them are negative. So they all have some marker of C. diff, whether it's just this non-specific GDH antigen, or whether it's the NAT, or whether it's the toxin EIA. And so we're sort of comparing people, all of whom who have some clinical test indication of C. diff. But you see sort of a discrepancy between the level of colonic inflammation measured by fecal lactoferrin, where you have the lowest level, or the lowest median level, about 10 log micrograms per milliliter, versus NAT positive a bit higher, and then if toxin EIA is positive, a bit higher on the fecal lactoferrin. So sort of validating that as a measure of colonic inflammation. But what we really wanted to look at was the gut microbial features. And so there's a lot, again, that we did here, but I just want to sort of drill down on this concept of core features of bacterial ecology associated with infection. And what we found when we compared the same classes, GDH positive, NAT positive, EIA positive, and we looked at the copies of 16S per gram of stool of Clostridioides. So this is this sort of amplicon version of C. diff. That again, we saw this sort of staircase pattern where we did in fact find the highest levels of copies per gram of stool. Again, this is integrating both the 16S sequencing data and the qPCR data of Clostridioides. This is actually sort of a controversial topic in C. diff because there have been many attempts to develop ultrasensitive toxin assays that can really do a better job of discriminating C. diff colonization from infection. And there have been sort of disparate results from those assays, but at least in our cohort of 384 subjects, we did find that the amount of Clostridioides was associated with toxin positivity. And just doing a univariable model, the Clostridioides odds ratio was 1.07. Here's the confidence interval. I'm not going to dive into the details of how challenging it is to do sort of multivariable regression with these microbiome data sets, which have thousands or tens of thousands of measured species or amplicon sequence variants. I'm very grateful for the fact that Jason Roy, who's at biostatistics and epidemiology here at Rutgers, has been a collaborator with me on this. But suffice it to say, it's challenging to develop regression models for microbiome data, but it's something I think is very worth doing. And I'll just mention that our multivariable regression model implicated Lactospiraceae as a protective component of the gut microbiota, which has sort of been shown in other studies as well. That's even after accounting for the baseline risk associated with differences in the abundance of Clostridioides. So interesting findings again.
Brendan, I wonder if I can ask, if you can go back.
Yeah.
I'm just surprised that the Clostridioides copies are so low, even in your top group. Looks like maybe the mean is 10 to the third per gram. It's not much. When somebody has salmonella or shigella or campylobacter, they have like 10 to the 6th to 10 to the 9th per gram.
It's a great point. I wonder if, I haven't included here, but the part of the risk of developing C. diff is so much prior antibiotic exposure. And I wonder if part of what you're seeing in the sort of low 16S qPCR numbers, that is sort of our denominator or our multiplier, 16S copies per gram of stool, may be lower than as you're saying you see with other enteric infections, perhaps because so many of these subjects had pre-treatment with antibiotics. I'm just sort of throwing
Yeah,
that out.
but that might move it in the opposite direction because the
To
denominator.
free C. diff to replicate. Yeah, no, that's a fair point. Yeah,
Yeah, that's interesting.
that's a great point. Yeah. So I know I'm going at breakneck speed, but I'm trying to shoehorn too much into this. I'm just excited to to share this up. But just to sum up the bacterial ecology of infection. So in broad strokes, bacterial infection, both VAP and C. diff, associated with dominance or increased abundance of a single strain, and low diversity does predict risk for respiratory tract infection. I have to sort of caveat this, where this is not the case for all lower respiratory tract infections. And in fact, Marty and I were talking earlier today about work done by Leo Segal's group at NYU that shows that for mycobacterial infections, that's not the case. So mycobacteria are not dominant, and yet they still cause lower respiratory tract infection. But for most pyogenic bacteria, this seems to be the norm, that in the lungs, dominance of a single species or strain or sequence variant is associated with risk for infection. And our C. diff data, again, sort of highlights a little bit of the same theme, where abundance does seem to matter and relative abundance does seem to matter. I think the fact that low diversity and dominance are associated with infection itself, even prior to antibiotic treatment, just highlights the fact that repopulation is a crucial element to recovery from infection, and that we need to focus on repopulation post-treatment, because part of infection is exclusion of normally present microbes. All right. So with that introduction, I'm going to jump to the next major topic, which is thinking about antibiotics and this sort of empty island model. So what are we destroying, when we put the tent over a patient and give them lots of antibiotics? And the key questions here are, how do different antibiotics impact gut and respiratory bacterial communities? This is sort of tricky because we think of antibiotics as having a very well-defined spectrum of activity, right? We've got our Sanford guides and we just look this stuff up. But in fact, that's sort of in vitro, and in vivo, there are complex interactions and conferred resistance. And so it's really, really challenging to predict. And there's also a huge difference in what sort of baseline microbiota look like in my gut versus yours. And so it's very hard to predict, actually, the impact of different antibiotic classes on succession and extinction in a real human being's gut microbiome. And then we want to think about implications of antibiotic selection and duration for repopulation. So how do we position ourselves either for healthy repopulation versus unhealthy repopulation? And so one of the first studies we did of this was, again, with one of my mentees, Matt Ziegler, who's fantastic, and again is focused on the oncology population. He was interested based on data that came out of Memorial Sloan Kettering, Eric Paymer and Ying Tor's group, that showed that low gut microbial diversity during the period around stem cell transplant was associated with long-term adverse outcomes, including an increased risk of mortality long-term. He was interested in understanding how antibiotics given during induction chemo affect the gut microbiota. And specifically how different classes of antibiotics. This was during a period at HUP where we were just introducing levofloxacin prophylaxis, primary prophylaxis for allo bone marrow transplant patients. And so it was sort of a good natural experiment to be able to compare the introduction of that levofloxacin prophylaxis. So we enrolled 60 adults who were admitted either for induction chemo and stem cell transplant or just chemotherapy. About 42% of them had AML. I think another 30% or 40% had multiple myeloma. So those were the sort of big bulk of diagnoses. Again, we captured stool specimens for 16S ribosomal RNA sequencing. We were interested in comparing across the antibiotic classes what the bacterial community diversity was and what the membership of the microbiota was. And so here's sort of a quick breakdown. So this was not a randomized trial, right? So we've got sort of messy overlap of some of the antibiotics. And one of the interesting factors here is as soon as levofloxacin was rolled out as a primary prophylactic intervention, people became very interested in oral vancomycin as a primary prophylactic intervention as well in this population. And so you've got your 60 patients here. Very few of them don't get levofloxacin or a broad spectrum beta-lactam. So the breakdown was basically the prophylactic levofloxacin, or if you didn't get prophylactic levofloxacin and you became febrile, you got a broad spectrum beta-lactam antibiotic. So very few of them get nothing, although even some of the nothings get oral vancomycin. And then you've got some that get levofloxacin, some that get levofloxacin and then get a broad spectrum beta-lactam anyway. And those get no oral vancomycin. And then you've got some who get the broad spectrum beta-lactam and some with the oral vancomycin and some without. And so we wanted to compare the effects of these different antibiotic interventions on both the diversity of the community, which I described earlier, of the gut measured by the stool sequencing, and also we had been interested based on prior literature, specifically in the Bacteroides proportional abundance. And what we found, just to go very quickly, was that levofloxacin was the only antibiotic that did not significantly decrease the gut microbial diversity. Oral vancomycin had the largest effect. Oral vancomycin also substantially reduced the gut Bacteroides, as would be expected, proportion, and significantly increased the dominance in the gastrointestinal tract of a non-Bacteroides genus. And these effects mostly held up to multivariable analysis as well. I'm not going to dive into it now, but although we focused on Bacteroides or Bacteroides rather, this is a principal coordinate analysis looking at sort of reducing to 2 dimensions the aggregate bacterial community shift associated with levofloxacin and broad-spectrum beta-lactams. And just to say that you'll have to look at the paper, but we did find other significant differences, although most of the story was the effect of Bacteroides. So that was one approach to look at the effect of antibiotics on gut microbial succession and setup for repopulation. Another study that we've done looking at the effect of antibiotics has been focused on that long-term acute care facility cohort that I mentioned earlier. And so we were specifically interested not only in aggregate microbiome change, but we realized early on that a huge fraction of these LTAC patients were developing Pseudomonas lower respiratory tract infections, as is common in the LTAC population. And so we wanted, and many of them had recurrent Pseudomonas FABs. And so we wanted to find post-antibiotic microbiome features that were associated with risk for recurrent Pseudomonas FAB. That is, take patients who we know have Pseudomonas in the lower respiratory tract. We know they've been treated with anti-Pseudomonal antibiotics, and then we're going to follow them after antibiotic treatment because we have this sort of nice long window in the LTAC setting, and we're going to look at how different changes in the respiratory microbiome portend risk for recurrent infection versus not recurrent infection. We also did metagenomic sequencing here for our microbiome analysis, and we cultured the Pseudomonas isolates and performed whole genome sequencing as well. Again, really interested in defining features associated with or without recurrent Pseudomonas infection. Again, there's a lot to sort of talk through here, but I'm just going to sort of go through some of the highlights. And so this was striking to us. So these were 17 subjects who had been treated with an anti-Pseudomonal for presumed Pseudomonas FAB. And we looked at them. They had lower respiratory tract specimens collected between 14 and 21 days post initiation of appropriate antibiotic therapy. And this is looking at on a log scale at how much what the Pseudomonas proportional abundance was in the lower respiratory tract after appropriate treatment, phenotypically based on sensitivity testing for their Pseudomonal infection. And you see a huge range here. So some subjects after their 2 weeks of treatment still have 100% of their 16S ribosomal RNA, or this was shotgun metagenomic data, reads assigned to Pseudomonas. Now, I have to say that one of the challenges with sequence-based analysis of the microbiome is that there's a lag after bacteria are killed where DNA is still detectable. But again, this was between 2 and 3 weeks out past the initiation of antibiotic treatment, and you still see really high abundance of Pseudomonas in some subjects, but it ranges widely. So many subjects have a lot of subjects have just down to 1% abundance of Pseudomonas in their lower respiratory tract. And so we were interested in looking at how this related to risk for recurrent infection. And it turned out that these subjects did in fact have a higher risk of recurrent infection. That is, persistence of Pseudomonas at the end of treatment measured by sequencing of the lower respiratory tract does predict risk for recurrence. And so we wanted to dive in further and figure out what was driving the persistence of these strains. And what we found by doing whole genome sequencing on the isolates that were present at the conclusion of antibiotics, the isolates that persisted at high proportional abundance at the conclusion of antibiotics versus those that didn't persist at high proportional abundance was that when we looked at a bunch of candidate genes for in the Pseudomonas whole genomes associated with risk for the duration of persistence, we found a lot of hits on these efflux family genes, which the porin and efflux system obviously a significant contribution to Pseudomonas' antimicrobial resistance. And it was, I think, in our eyes at least, had a lot of validity that some of our biggest hits were from the OPRMX and Nalgene families, highlighted in blue here. This is sort of a Manhattan plot where the strongest associations with Pseudomonas persistence in the lower respiratory tract are higher on the y-axis and the vertical axis here. And so MEXX was the most strongly associated factor, but a bunch of other OPRMX and Nalgene families or porin efflux system families showed up in our analysis as well. We think, though, that it's not just a story about Pseudomonas, because even after we adjusted for how much Pseudomonas people had residually in their lower respiratory tract system, and we started looking at what other microbes were present with that Pseudomonas, we found that there were apparent interactions between other microbes in the lower respiratory tract and Pseudomonas. That is, if you have 50% Pseudomonas abundance in your lungs and I have 50% Pseudomonas abundance in my lungs, but we have different partners with the Pseudomonas, we may have different risk for recurrent infection. And the one that popped up with the sort of highest association was a single sequence variant of Streptococcus, which was present in a bunch of different patients with persistent Pseudomonas. And as the abundance of that Streptococcus sequence variant increased, so too did risk of Pseudomonas recurrence, that is recurrent lower respiratory tract infection, even after adjusting for what the abundance of the Pseudomonas was. So certainly there are features of Pseudomonas associated with persistence in the lower respiratory tract that may not show up on phenotypic testing, and the abundance of Pseudomonas at the conclusion of treatment matters, but there's also likely interactions with other members in the lower respiratory tract that are related to infection risk. As I said before, as we think about antibiotics decimating populations in the respiratory and gastrointestinal tract, we have to think about what is available to repopulate the gut and the lung. And so we've been studying the microbiome, not just of hospitalized patients, but also of the healthcare environment. And this was an initial study that we did where we tried to define the presence in the healthcare environment of multidrug resistant organism contamination, and also in parallel to sample the microbiome so that we could understand how bacterial DNA was deposited. That is, what does contamination look like? And then relative to that bacterial contamination, where can we find culturable MDROs? That is, where is the environment sustaining living bacteria in the environment? And so to do this, we enrolled 51 hospital rooms where a patient was admitted with a multidrug resistant infection. We performed composite, that is one swab for a bunch of different surfaces, sampling of the near environment. So that was sort of the bedside table, the bed rails, the foot of the bed, the remote, intermediate sites. So these were sort of floor and wall areas halfway between the patient and the bathroom. And then far swab sites were away from the patient's bed and towards the patient's toilet, including the sink and toilet sites. And we performed, again, culture and 16F sequencing. And the goal, again, was to understand both bacterial contamination and where bacteria were able to sustain their populations, and we could detect them by cultures, particularly multidrug resistant bacteria. And here's what we found. So here's a bunch of different multidrug resistant bacteria, and I'm going to show you the culture data first, and then I'll show you the 16S data so you can sort of compare. So here on the y-axis, you have the probability of us finding the specific multidrug resistant organism, whether it's Acinetobacter or Citrobacter, Enterobacter, a bunch of different ESBL and carbapenem resistant gram-negatives, or MRSA, Pseudomonas, et cetera. And on the x-axis, the horizontal axis, you have the distance as you get farther away from the patient and towards the toilet. And what was striking is that for a bunch of the multidrug resistant gram-negatives, we found very low risk near the patient, but as you got near the bathroom wastewater sites, the likelihood of finding these MDROs increased dramatically. This is not new news. So bathrooms and wastewater sites being, harboring MDROs, particularly gram-negative MDROs, has been reported before. But what's striking was the opposite pattern for MRSA and for Clostridioides. So we actually found that you're more likely to find MRSA and C. diff near the patient, opposite from the gram-negative MDROs. And so when we broke things down actually by gram-negative, gram-positive, we saw this really interesting relationship where gram-negative MDROs rose in likelihood of finding them as you get towards the toilet and away from the patient, and the gram-positive MDROs sort of fell as you move towards the bathroom and away from the patient.
Brendan,
yeah.
did you look at it by spore former or non-spore former?
We did not break that down. It's a good point. And I will say, one concern with this always is with our nucleic acid extraction methods. We may be underestimating the burden of spore producing organisms. It's a very good point that we may not be accurately capturing that. Although we had a lot of luck with our C. diff culture methods, probably our 16S sequencing was a little bit undersensitive. What I just want to point out is that the patterns in culturable MDROs actually sort of run counter to 16S bacterial DNA deposition. So staph, you remember, was more likely near the patient and then fell away towards the bathroom, and Pseudomonas was more likely near the bathroom and fell away towards the patient. But what you see is if you swab the floor, if you swab the bedside, if you swab the toilet, you find in every swab staph bacterial DNA, and likewise you find in every swab Pseudomonas bacterial DNA. So it seems like deposition of these organisms is universal. Staph and Pseudomonas, that is. There's a little bit of a difference in some of these, but that what really matters are the different surface sites in terms of sustaining population, or perhaps near the patient, continual deposition to sustain populations of the bacteria that we can culture from the environment. And so this comparison of DNA deposition and culture is one that we're sort of bringing to bear in a bunch of different studies. But I think the point of this, again, is just to highlight that this is what's out there, ready to repopulate the gut and the lungs after antibiotic treatment. So closing statements on antibiotics and empty islands. We saw large effects of antibiotic selection on the post-antibiotic gut community, differences between broad-spectrum beta-lactams, levofloxacin, and oral vancomycin. We saw how differential repopulation can impact Pseudomonas reinfection risk. And so again, to highlight here, passive repopulation is an invitation for an MDRO-rich environmental microbiome to repopulate the gut and the lungs. And so now let me move into the third piece of this, which is focused on what we can do to intervene. And again, I'm going blazingly fast just to sort of touch on some of the fun stuff that we've been up to and give you a sense of what we're working on. So how can we engineer the microbial community after antibiotics? So antibiotics are a blunt tool. Are there any better tools to sort of more precisely control repopulation? What's the effect of FMT, and what's the effect of bacteriophage therapy, which is sort of an increasingly investigated intervention to specifically target single bacterial strains? Excuse me. So FMT has been studied broadly for C. diff, and I alluded to the fact that multiple clinical trials demonstrate its efficacy for recurrent C. diff infection. And we're at a very exciting juncture where we expect sometime this summer, probably, the first sort of synthetic FMT product to gain FDA approval for treatment for C. diff. We did a trial that was looking at another indication for FMT, which is severe C. diff infection, where there's less evidence, although some observational studies to suggest it's effective, but where we thought that clinical trials are needed. Sadly, our trial was disrupted over and over and over again by COVID and by FDA strictures on our FMT manufacturing process. So we only enrolled 24 subjects, which sort of broke our hearts a little bit, but I will show you a little bit of that data. I just wanted to highlight that to do this, we developed 3 FMT products. So I led the development of a rectal enema, an enteral tube liquid, and a frozen oral capsule FMT products called Pen Microbiome Therapy, or PMT 001, 002, and 003. And fortunately, although this trial was really disrupted by COVID, we have gotten funding to do a trial of these 3 products for the treatment of multidrug resistant organism colonization. So we're excited about that and kicking that off soon. So here we randomized subjects with severe C. diff infection to either standard of care antibiotic treatment, that was the control arm, or standard of care antibiotic treatment plus up to 3 serial fecal transplants. And the endpoint was time to resolution of severe C. diff symptoms. Unfortunately, I cannot show you the outcome data because it's still being adjudicated and we have our final DSMB meeting coming up, but I will show you a little bit of our pilot microbiome data. This was just the first 7 subjects. And what you have here is days post FMT, if they got an FMT or randomization to control, from 0 to 10. Those subjects that received FMT are highlighted with gold dots at each time point and then a line connecting their time points. And those who received standard of care antibiotics, blue dots and blue lines. And these are, again, severe C. diff patients. And on the y-axis, you have the gut bacterial richness, or just the number of species measured. Again, I can't tell you anything about outcomes, but I will say that, you know, when patients get better or leave the hospital, it stops sampling them. And so what you see here are 2 of the FMT recipients, one early and then one sort of late, who have dramatic increases in the gut bacterial richness, but both standard of care subjects and 3 of the FMT randomized subjects who have essentially very few bacterial species measurable in their gut. And so this is just a demonstration of, even in severe C. diff, the potential impact of fecal transplant. The other piece I wanted to tell you a little bit about is something that's really hot off the presses, but we were interested not just in interventions to control repopulation in the gut, where FMT is a really powerful tool, but also interventions that could help control repopulation in the respiratory tract. And this is an area where exogenous bacteriophage therapy has become a really exciting option. So the engineering of lytic bacteriophage targeting a known multi-drug resistant pathogen often that are given in synergy with antibiotic treatment to help eradicate an infection. We actually wanted to try a different strategy. So we noticed that when we first did our study of Pseudomonas persistens, that in our metagenomic data, we found a signal that those subjects who did not have recurrent infections had higher read counts for certain, again, in metagenomic data, for certain Pseudomonas bacteriophage. And so we wanted to better characterize the endogenous bacteriophage population in the lungs, already living in the lungs of subjects with Pseudomonas lower respiratory tract infection. And so 45 of our LTAC subjects had Pseudomonas that we could culture from the lower respiratory tract. And we performed whole genome sequencing of those isolates, but also we cultured those isolates so that we could perform induction therapy. We had also found to induce into the lytic phase bacteriophage that had been in lysogeny. And so we also found that in our human subjects data that there were certain medications that seemed to be associated with the detection of these bacteriophage. And so we were interested in whether any regularly administered medications could succeed in inducing these bacteriophage from Pseudomonas, with the idea that perhaps post-antibiotic therapy with some benign medication could allow for continual phage induction and thus control residual pathogen populations in the lungs and allow for more healthy repopulation of the lower respiratory tract. And so this was the sort of crux of the study. And so what we found was that Nacetylcysteine, or NAC, which is often given inhalationally to help as a mucolytic, was actually successful in inducing bacteriophage from these multi-drug resistant Pseudomonas isolates that we captured from our patients. So here you've got bacterial growth curves. So we're looking at Pseudomonas in its exponential growth phase. And in blue, we've got sort of a control Pseudomonas where we just add a little bit of buffer midway through its exponential growth. And then the other colors, gold, is we add mitomycin C, which is a known bacteriophage-inducing agent at the midpoint of exponential growth. And the red is adding N-acetylcysteine. And you see some of the red tracks just sort of follow the control, that is, you don't induce phage with NAC, but others show a partial response, and some others show sort of great potential phage induction, that is, it's sort of bending the growth curve of Pseudomonas growth with N-acetylcysteine. We characterized the presumed bacteriophage that we identified by this method, either by mitomycin C induction or NAC induction, and by testing, by plaque forming assays and spot testing on other Pseudomonal isolates. We extracted the DNA, we performed shotgun metagenomic sequencing, and because some of these phage are not well characterized, we did de novo sequence assembly, and we got these really nice round genomes, putative genomes of about sort of 30 to 50,000 bases, which is sort of consistent with what we think of as a typical Pseudomonas bacteriophage size. There are sort of bioinformatic algorithms. The one we use is VirSorter that look for sort of characteristic or hallmark genes associated with bacteriophage and assign a maximum identity as well as a viral identity score. And all of these had really high hits. Max score is 1, suggesting that we really were detecting from these samples inducible bacteriophage in these clinical Pseudomonas isolates from subject lungs and bacteriophage that are both inducible with Nacetylcysteine and also demonstrate cross-lytic activity against other multi-drug resistant Pseudomonas isolates. So this is another potential avenue to helping control bacterial repopulation post-antibiotic treatment. So just to sum up the microbial community engineering piece, post-antibiotic bacterial community succession can be altered by either introduction of bacterial communities via FMT or induction of integrated bacteriophage or the introduction of exogenous bacteriophage as is being piloted by a lot of biotech companies. And I think of this again as sort of 2 models for engineering post-antibiotic bacterial communities. One is you get your antibiotic conditioning and then you get a transplant. The other is that you get sort of induction therapy with an antibiotic and sort of knock down a lot of bacterial species, but then we do narrower or more targeted consolidation therapy with either an introduced bacteriophage or induced bacteriophage so that we can allow sort of healthier repopulation after antibiotic treatment. So my conclusions in the remaining minute are about how we're entering the LBP era. So I think I mentioned this before, but this is the term that seems to be sort of catching on for all of these emerging products, live biotherapeutic products, LBPs. And again, it's big news that in the New England Journal last month, Series Health had positive phase 3 clinical trial findings for one of its LBPs that targets recurrent C. diff infection. And we've got sort of first approval of the Series product and possibly the Rebiotics product expected this summer. There are a bunch of other companies working on C. diff targeted LBPs, but there are a bunch of other applications that are in development too. LBPs for inflammatory bowel disease, I mentioned before for PD-1 inhibitor or immune checkpoint inhibitor potentiation. We're doing a study of FMT for MDRO colonization, and others are interested in that as well. I think Vedanta is developing a product to try to mitigate food allergies. And so this notion of repopulation of the gut, I think, is important, not just to deal with what we deal with every day, which is the risk for recurrent infection, but also for all these other potential avenues of intervention and for potential avenues of intervention that I think infectious disease doctors should be leading. That's my opinion. So in conclusion, bacterial infections like that and C. diff are characterized by a low diversity or dominant state, which emphasizes the importance of post-treatment repopulation. Antibiotics can exacerbate this low diversity state, and they can do so in a class-dependent manner. Late reinfection may represent a failure of post-antibiotic repopulation. I think it's not just C. diff. I think this is a more common phenomenon. And passive repopulation from the healthcare environment, where we have patients just sort of hanging around the hospital as they come off their antibiotics, risk MDRO colonization given the prevalence of MDROs in the healthcare environment. As we think about more rational ways to engineer repopulation, I think the leading sort of therapies that are coming forward are FMTs and LBPs, but I think bacteriophage therapy in sort of a different model can also be a powerful intervention, either exogenous bacteriophage or the sort of induction model that we're trying, so that we can exert control over post-antibiotic repopulation and prevent recurrent infection. And that's my talk. I want to thank a million people, but most of them, most importantly, Matt Ziegler, who's done led a lot of this work and has been a wonderful mentee. Sean Lockery in my lab, who leads a lot of the bench analyses. Rick Bushman at Blattenbach, who've been tremendous mentors, and CDC and NIAID for funding. And with that, I will ask if anyone has any questions.
So thanks so much, Brendan. I think we're right at 2. I'm happy to. I think Brendan and I can stick around for a few minutes if people have questions. If you need to drop off, I think we totally understand.
I've got one question,
Marty?
Brendan. you have to go back to around slide 10. I can't remember the exact slide number, but
I'm sorry.
it was when you were looking at the recurrence of infections after that one. Yeah, the next one then.
This one?
Yeah, that one. You know, what was interesting to me is look at the difference in the shapes. Look at the shape of Enterococcus versus Enterobacter. And you
Yeah.
see it both for bloodstream and urinary tract infection. That difference is telling us something. The Enterococcus is coming on very fast. Maybe it's when the vancomycin has stopped. I'm not really sure, but that's not random.
No, that's a great point. Yeah. No,
And you see some other organisms that, you know, Enterococcus is the most severe, but look at the difference between Klebsiella and Enterobacter, you know, and Klebsiella and E. coli. I think these shapes actually tell you something about the ecology. So.
Yeah, I really think this is sort of an exciting area to dive into. That's a great point. Just looking even at sort of the distributional.
And it's also consistent. Look at between bloodstream and urinary tract, the Enterococcus, the Klebsiella, Pseudomonas. So I think you found something. Now you have to develop it.
Any other
Hey, Brandon.
questions? Oh, sorry, go on.
Yeah, it's Leanne Chen. I'm one of the gastroenterologists here at Rutgers.
Hey.
And I wanted to, I guess, pose a question / comment. I know that there's some very early data about ursidile use. And so given its, ability to suppress C. diff sporulation, et cetera, there have been some groups that have started using this as off-label therapy to prevent C. diff recurrence in patients who have recurrent C. diff, and while the patient's having time to kind of restore their endogenous microbiome. And so I was just curious, about your thoughts on that, and I guess perhaps bridge therapies that we can use while we wait for, I guess, a more natural microbiome development.
Yeah, no, it's a great question, and I think it points to the complexity of these interactions. Right, we know that secondary biometabolism by bacteria is a huge part of colonization resistance to C. diff and sort of resistance to C. diff vegetation. And so, yeah, I mean, I think the challenge is that every intervention is an interaction, right? It's like an interaction with, our baseline health status, and interactions with the microbiome are more complicated because they're interactions with all these different bacteria. And so I think, the challenge, I think, with ursidile is that I can imagine that you have, risks for false negative findings if they don't have the right microbiome, because it's the effect on C. diff protection probably relates not just to the administration of ursidile, but also to secondary bile acid metabolism by the residual microbiota in the colon. But I think this is the fun part. We got to learn this so that we can use these tools. And yeah, it's exciting to think about that. And I agree with you that we need all the tools possible to address C. diff because it keeps coming at us.
Still a problem. All right, thank you, and very much enjoyed your talk.
Oh, thanks.
All right, guys. Thanks, everybody. Brendan, enjoy the rest of your visit, and thanks for a great talk. Really appreciate it.
Thanks. All right.
Bye.
Bye-bye.